Good morning and welcome to today's webinar, Aging in a Rural Place. I'm Justin Newman, the Director of Strategy and Partnerships at the Centre for Aging Better, and I'm really delighted to be here. My background and passion is very much rooted in place, having worked in local systems, through local government and the NHS for 20 years. And being born and growing up in East Yorkshire, I have a real connection with many of the issues that I hope we'll be talking about today. So, as well as welcoming all of you to today's webinar, I'd like to make a special welcome to our speakers today. I'm joined on the panel by partners who have a wealth of experience and knowledge about what ageing in a rural place looks and feels like. So shortly, we'll be hearing from Dr. Jessica Selleck from the National Centre for Rural Health and Care, Rob Fountain from Age UK Gloucestershire. We have Jan Thornton, who, as well as being a trustee for Rural Action Yorkshire, holds a number of leadership roles focused on rurality. And we have Glenn Garrod, the Executive Director of Adult Social Care and Community Wellbeing from Lincolnshire County Council. But before I hand over to our speakers, I just wanted to share a couple of housekeeping points and then say a little bit about what has brought us here today. So in terms of the housekeeping, we are streaming this session live on Aging Better's YouTube channel, and the webinar will be available to view on demand immediately after we've finished. All live attendees are in listen-only mode. So if you have questions for the panel, please post these using the Q&A button, which you'll find in the control ribbon at the top or bottom of your screen. So after the 4 presentations we have planned, we've got a good amount of time to have a Q&A session to pick up on some of those killer questions that you'll be posting, each of us. And one of the benefits of these online events is that we also have the chat function. So as the conversations are going and we've got questions posted and people are raising issues, please do use the chat box for any comments you have or responses you want to make. And finally, on housekeeping, those of you tuning in on YouTube are really welcome to join the conversation on Twitter using the hashtag AgingBetterEvents. So turning to what's brought us here today. Today marks the launch of our paper, Aging in a Rural Place. It's a really, really important milestone for us at Aging Better as we look to ensure that our work reflects the needs, issues, challenges, and opportunities that living and working in a rural area means for people as they approach later life. Last year, despite the many challenges that were posed by COVID-19, we were really delighted that with colleagues in Lincolnshire, we were able to launch our 5-year partnership. And that means that we can take forward a shared vision of what society can and needs to look like to ensure that people can enjoy later life. But on the journey to agreeing that partnership with Lincolnshire, we engaged with a wide range of organisations and areas who'd expressed an interest in joining with us with the same intention and ambitions around this agenda. It was clear to us that there was a network of passionate and committed colleagues, organisations from across the country who we could learn from, who were full of knowledge, experience, lots of ideas about the things that could and should be done, and who'd be keen to come together to continue to ensure that the unique strengths and challenges that rural and coastal places hold, and that they are considered and reflected in decision making and policy going forwards. So the Aging in a Rural Place paper that we've launched today, and a link to the paper has been posted in the chat for you, captures the learning that we've gathered on our journey so far, with contributions from a wide range of people and organisations across England, north, south, east, west of the country. The report is packed with insight, lots of experiences described in there and case studies, and in bringing it all together is intended to help us raise awareness amongst decision makers and identify some of the priorities for action if people in rural areas are really to enjoy later life. So before I finally stop talking and hand over to our esteemed panel members, I wanted to very quickly set the scene. We have a vision that by 2040, we want more people in later life to be in good health, financially secure, to have social connections and feel that their lives are meaningful and purposeful. But we recognise that the experience of living and ageing in a rural or coastal area can differ vastly to those in urban towns and cities. We know rural life and the way it's perceived and described can sound hugely appealing. Rural areas thought as offering more peace and quiet, a slower pace of life, access to beautiful countryside or a coastline, pictures painted of more opportunities to stay active, a greater sense of community spirit, and lots of other benefits. And for some or many, this is no doubt true. However, this report and the paper we published shows that for many of those in and approaching later life, the reality of rural life can be different. Underneath some of the really positive and overarching measures that show those living in rural areas as having higher life expectancy and better well-being, there are a series of hidden inequalities. Those higher levels of home ownership disguise higher levels of fuel poverty. Some strong community spirit and social capital masks pockets of social isolation. Higher average life expectancies overall hide some communities with much poorer health outcomes. And the list goes on. I'm sure that the conversation today will touch on other challenges often posed by the geography. So there are issues we know about access to services and transport, barriers to social connection and work, poor digital infrastructure. And of course, the COVID-19 pandemic has shone a light on all of these and made many of them worse, widening inequalities. Thankfully, the paper isn't all doom and gloom. It puts forward a really positive case for change and a clear set of priorities for action for rural places. And today we have a webinar full of people, speakers and attendees who have the ideas, influence, networks and energy to help move forward in a positive way to tackle head on the challenges posed, particularly by the COVID-19 pandemic. And so on that note, I will introduce our first speaker. And just to remind you again, please do post any questions you have for our panel using the Q&A so we can come back to them in our Q&A session. So I would like to welcome to the stage Dr. Jessica Selleck. Jessica is from the National Centre for Rural Health and Care, and I will hand over to you. Thank you.
Well, thank you very much, Justin, and I'm delighted to join everybody this morning. I've been asked to speak today about 2 points. Firstly, what are the challenges of delivering health and care in rural places? And secondly, what has been the impact of COVID so far? And I've got a few slides covering each of those points. There is a full slide pack, which my colleagues will be circulating afterwards, and that contains more information about the National Centre and some of the things I'm going to talk to you about this morning. Okay, so if I think about the first point I was asked to talk about, what are the kind of challenges? For the National Centre, these really coalesce around these 4 areas: workforce, distance, size, and access to resources. So the first point, workforce, how do we attract, recruit, and retain the right workforce in our rural areas? And what we find at the National Centre is that recruitment's more difficult in rural areas. Particularly smaller and remote healthcare settings can be viewed as less desirable from a career point of view. And what that means is that sometimes some providers have to spend more money on locum and agency staff to fill those workforce shortages. There's also an increased level of independence and autonomy sometimes required to work in a rural area, and that can leave some staff feeling professionally isolated. So we struggle to attract, recruit and retain staff. The second area, distance and travel times, I'm sure that's familiar to everybody at the event today. Distances can be greater, so that means that staff spend lots of time having to travel to access patients, and that's kind of sometimes unproductive time. There are also higher costs of delivering certain health services in rural areas in order to meet kind of national standard and response times, so particularly things like ambulance services. We also find that patients can present later and when they're sicker too. And Age UK have done some really good work, which has been published in a report called Painful Journeys that explains older people and their experiences of trying to access hospital care. The third point, size. You've got fixed and sunk costs in rural areas, and you can't achieve the same economies of scale as if you were in an urban area. So rural areas we find tend to have higher unit costs, patients with complex needs that are more dispersed, And there are fixed costs, and you have to meet minimum staffing levels, regardless of the area that you serve and the population that whose needs you try to meet. And the National Centre for Rural Health and Care has been undertaking a parliamentary inquiry over the last 2 years. That's co-chaired by Anne-Marie Morris MP and Bishop Sarah Mullally, who was the chief nurse before becoming the Bishop of London. And we had an evidence session on ageing. And we had Professor Masood from the British Geriatric Society coming along to that session to give us some evidence. And he told us that only 14% of smaller hospital trusts have a dedicated frailty team, and that's because they just don't have the economies of scale to provide that service. And finally, under access to resources, if we want to deliver technology or deliver and kind of deliver training to staff, that can be more expensive and difficult in a rural setting. And it's also worth noting that whilst I'm talking today about the pressures facing healthcare services, there are a whole range of wider and interdependent factors here. So things like public health, housing, infrastructure, the environment. So it's important that we don't forget those as well. Within the NHS, there isn't a definition that's commonly agreed around rurality. So there's an organisation called ACRA, the Advisory Committee on Resource Allocation, and they make recommendations to the Department for Health and Social Care in NHS England about the national budget for health and how that might be targeted at local areas. So they don't make the decisions, they just present the data and make some recommendations. So ACRA use this term unavoidable smallness due to remoteness to think about the rurality factor in terms of how we target that funding. And they look at two things. Firstly, which hospitals serve fewer than 200,000 people? And secondly, what proportion of the population do they serve for whom the next nearest hospital is more than 60 minutes away? And this table on this slide has been prepared for the National Centre by the Nuffield Trust. And what it shows is that those trusts that are deemed unavoidably small have longer waiting times, longer lengths of stay, more delayed transfers of care, higher unit costs, and they're in a worse financial position compared to other trusts. The slide also contains a list of hospital sites. And when you look at the trusts who manage those unavoidably small sites, whilst they only account for 3% of the total number of NHS trusts, they actually carry 23% of the deficit. So at the National Centre, we're really interested in having a better understanding of rural and thinking about how that can inform policy decision making and funding. At the National Centre, we're also really interested in adult social care, and the parliamentary inquiry has been collecting evidence on that. And there are three key issues coming up: sustainable funding, staffing, and technology. And what these two charts show is the chart prepared by the National Centre for Rural Health and Care. We contacted our members and did some analysis, and whilst the green line shows that the over 65s account for less than 30% of the population, some local authorities are spending 40% of their budget on adult social care, and some are spending a lot more than that. And ADAS, the Association of Directors of Adult Social Services in England, do an annual budget survey. And one of the questions they asked the directors of adult social care was how confident they were about having the budget being sufficient to kind of meet the future need. And I think the chart shows how unconfident those directors are. I think it's worth pointing out as well that local authorities have to set a balanced budget by law, whereas NHS trusts can run a deficit. So in terms of, what impact has COVID had on some of the challenges that I've just briefly outlined to you? And I would say really since the start of the pandemic, those challenges have kind of become more intensive, and we've also thrown up some new challenges as well. And what the Centre's done is work with the Nuffield Trust to develop a rural COVID dashboard, and this provides a snapshot of this. And what that looks at is, what impact is the pandemic having on some key sectors within healthcare? So general practice, secondary hospital care, social care, mental health, ambulance waiting times. And there's a link in your slide pack to look at that dashboard, but I just wanted to draw your your attention to some of the kind of key findings. So what we're finding is that COVID has had a detrimental impact on hospital waiting times, particularly for rural trusts. So if you look at cancer care, the proportion of patients being seen for their first appointment has dropped by 66% in rural trusts compared to 59% in urban trusts. We're also finding that activity has fallen in rural areas, so emergency admissions are down, referrals for mental health provision are half the level that they were pre-pandemic. The pandemic's also exacerbated some workforce issues, that we're having to spend more money on temporary staff in rural areas, even though actually we're kind of recruiting more staff. And the underlying position of rural trusts has actually worsened. And in terms of adult social care, certainly providers are telling ADAS that they've either ceased trading, or they're going to hand back their contracts. So I didn't want to end on all doom and gloom. And so one of the great things that the Parliamentary Inquiry has been working at is collating examples of good practice. So things that have started before the pandemic that have really come into their own during COVID. And I've put some examples on this slide for you. So just to give you a brief overview, around workforce, community catalysts have been working with local authorities and communities to support individuals to set up their own tiny enterprises to provide adult social care. And they've now got a few hundred people supporting 2,000 people around all of that. Around the things that are going on in West Suffolk, they've used a model from the Netherlands, which involves bringing together a small team of nurses which work across professional boundaries. So they provide clinical, social and personal care to people in a local community. The Airedale Foundation Trust have done some really innovative work in setting up a digital care hub that provides telephone and video calling, and it's run by a multidisciplinary team, and that's been particularly helpful during COVID around supporting people around end-of-life care and supporting residents in care homes. Around how do we get to people quickly in an emergency, we've got Lives, which covers Lincolnshire, and other community responder schemes work in other areas. Lives responds to about 15,000 calls a year, and their community responders, who are all volunteers, 83% of them arrive before the ambulance gets there. They've also just started running some doctor cars that can now respond to category 2 calls in rural areas, so things like stroke and serious injury. Healthier Fleetwood is a really good example of a GP practice and communities working together. The GP had a patient who came to see him who told him that it wasn't the fear of dying that worried him in old age, it was the fear of living. So they've done a lot of work setting up some kind of community facilities and resources to kind of help people kind of better look after themselves and kind of gain confidence and improve their well-being. So in terms of what brings all of these points together and some concluding remarks, I think the work at the National Centre, we found that actually we need to move away from centralised and standardised approaches to health and care, because they don't work in rural settings because we don't have the critical mass or the chimney pots. That we need a much better definition of rural to inform our policy and decision making and funding. That the rural health and care needs of rural populations need to be better understood and measured in their own right. And that doesn't mean collecting more data. One of the things the National Centre is involved with Public Health England at the moment is to look at the deprivation data and put a rural lens through that. And the University of East Anglia have done that for Norfolk, and we've currently got the University of London doing that for Lincolnshire. And that's highlighting some really interesting things when you remove some of the filters, for example, the number of cars people have got, because that can skew the figures. And obviously people living in rural areas, they often need a car. We also think it's important to recognise what we call communitisation, that people want to live a life rather than be fitted into service models, and that we need residents in the lead and community-led solutions. And I'm really delighted that the Centre for Ageing Better is absolutely passionate about that. And finally, everything we need to do, we need to think about it at a place level and around localities as well. So I'll end it there. Thank you very much.
That's fantastic. Thank you so much, Jessica, and so much rich insight in there. And particularly, I was really taken by the notion of unavoidable smallness and the challenges that poses. So Fantastic. Right. I will move us quickly on to our next speaker, just again to encourage people to pose those questions in the Q&A box so that we've got some killer questions to pick up later on. And our next speaker is Rob Fountain. So Rob is from Age UK Gloucestershire, and I'll hand over to you, Rob. Thank you.
Thank you, Justin, and thanks for the opportunity to talk. So I'm the Chief Executive with Age UK Gloucestershire. So we represent older people, and we work with older people in the rural county of Gloucestershire, and we also have a bit of coastline as well along the banks of the estuary of the River Severn. And I was asked to talk about the impact of COVID on the voluntary sector in rural areas and what it can do to recover. Now, I think the starting point there is that voluntary sector is a term much like older people, which looks like it defines one thing, but is really describing a group that is not homogenous. There is a huge amount of difference across what constitutes the voluntary sector in our size, our approach, our financial model, our reserves, our reach, our attitudes, our staffing, volunteer mix, huge amounts of difference. And that difference means that how COVID has impacted on the voluntary sector will be very different. And I can't speak for all of them, but I will try and give a flavour of how it has felt for us as a sector, not as a single impact, but a range of experiences. The second comment is that the suggested title that talked about what the sector can do to recover sort of implies that we were hard hit by the pandemic. And I think I would like to start by saying I think overall the voluntary sector has performed a blinder in the last year. I think the sector has been exceptionally responsive in a crisis, often mobilised far faster than statutory bodies were able to do so. We have become the first point of contact for many of those who were impacted by COVID and the change that all of our lives experienced. If I take the Age UK Gloucestershire Help Team, we've handled over 6,500 inquiries in the last 12 months. And there were days in April last year where we were getting sort of 70, 80 calls a day, when our average before that was 20. So people were coming and turning to us. And the range of charities that people were calling upon that saw that increased demand had very uncertain at best funding, and yet we kept going. So I think there is important to recognise that I think the sector has performed very well during its most challenging year. But it is fair to acknowledge that there has been an impact from the pandemic. It's expected that a number of voluntary organisations will have or will shortly fold as a direct result of the pandemic. Others are very much looking to have to redesign and rethink their offer, what they are here for and how they're going to deliver it. So if not recover, there is certainly much that the sector needs to learn from and adapt to. So I wanted to just pull out 5 impacts that I think there have been on the sector, as well as concluding by drawing a bit of a picture of a cliff edge. So the 5 impacts, the first I think I'd want to draw out is the impact on our staff. And if I had to use one word to describe how our staff are feeling at the moment, it would be tired. They have worked extremely hard. The sometimes flippant comments about it's time to get the country back to work, they sit rather hard for us when people have been working very hard throughout. And I think much like health and social care would feel the same, that this hasn't been a period of pause, it's been a period of extremely intense activity. And our teams have been having to do that by not working close together. We're a county-wide organisation, and our organisation has morphed overnight in April last year to being conducted from living rooms, spare bedrooms and dining tables all across our great county. So the team haven't had each other to pull on in quite the same way. And our frontline staff, I think, have also been having to deal with increasingly complex situations. There has been a lot of bereavement issues that have been coming through, but we're also now seeing increasingly the impact of people who are really suffering with the deconditioning of a year of not being as mobile, not having things attended to over the last year. There's some real complexity in what people are coming forward to voluntary organisations for support with, at a time when I would say statutory bodies are still adjusting themselves. And so those difficult situations often land on the desks and on the phones of voluntary organisations. So I think we do need to think very carefully about how we support the people working in the voluntary sector who have already given much, are having to deal with very complex, emotionally draining situations, and are doing so often in organisations that are less secure and with less resources than those in other sectors. The second impact I want to talk about is the impact on how we actually operate. So 13 months ago, we'd never heard of Zoom, and here we are running webinars on it. But in the voluntary sector, we're also running social groups, exercise classes, ukulele groups, one-to-one support sessions for people. COVID has accelerated the use of digital delivery in the sector. I think that's particularly pertinent for us in the voluntary sector because we've tended to underinvest in digital and infrastructure over the years. Having efficient IT is a core cost, and one that, as such, many organisations are often reluctant to put money into because it makes us look expensive. It looks like we're putting money into things that aren't directly helping people with their issues. That this year has shown the fallacy of that. We need to have a voluntary sector that also has a strong infrastructure behind it if we'll be able to maintain delivery, not just in a pandemic, but in the 21st century. How we use this technology going forward is an important issue for us now. Remote working has been a real revelation for us, and for many working in rural areas, it may well prove to have shown us a better way in lots of situations. Certainly we've got, as I say, an ability to cover the whole county now in a way that is arguably easier than it was previously. But we know it doesn't work for all people. The lack of a physical presence in rural places over the last year is a concern. The fact that we've not been in communities with people all the time is something that we're lacking. And as was touched upon in the previous presentation, rural areas with the worst broadband coverage are again those that are most compromised at this time. So are we missing the people that may need us the most if we rely on digital? Voluntary organisations really are about face-to-face input, and how that returns after this shock of the last year is going to shape the sector for years to come, and how we blend that with digital is an interesting consideration. The third impact is on what we actually do. The pandemic changed that for many of us overnight, partly because we had to reposition how to provide previous activity in a COVID-secure world, but also because we were asked to respond to entirely new requirements. Voluntary sector organisations have been doing food delivery, making telephone welfare calls, providing transport to vaccinations, if not running vaccination clinics, a whole range of things that we didn't do before that we're now having to find ways of making it happen. With Age UK Gloucestershire, we also found ourselves doing much more this year in hard copy publications. So recognising that digital wasn't available to everybody, we created back in the autumn some new activity packs that we printed, we posted and got hand delivered through our communities. And through these, we've seen a surge in what we're sort of calling community by correspondence, with people really seizing that opportunity to engage from their homes with others around the county. And doing that in ways that we thought maybe were becoming redundant, we've actually seen that these are actually very well received and making a massive difference. We've also been drawn more into campaigning. We've had to take a position locally in challenging some of the local decisions around care home visiting, for example. But we've also been looking at how we get involved in wider community influencing. During the first lockdown, encouraged neighbours to meet for a cup of tea at a set time each week from their doorsteps and at the front of their properties. And that was about us using our profile to give permission and just some very simple tools for neighbours to arrange this themselves. So we're getting involved in new ways of working. We're required we're having to develop some new skills that we didn't necessarily have before, and we're encountering new challenges of how we measure the impact of this activity that's happening away from our front door. But we're definitely seeing results that are showing more effective ways of working in the future. The fourth impact I would talk about is the impact on finances. Now, the pandemic has been punishing, particularly for those charities who diversified, as encouraged over the last decade, to move into chargeable services and to earned income to offset the fundraising income that they get. So day services, some home help provision, those things that rely on fee income were particularly hard hit. The same goes for small scale lunch clubs that run on subs, charity shop income that fell completely off a cliff, all deeply affected by the need to cease certain activities over the last year. Now, furlough was an option, But furlough is a philosophical challenge for a sector that is seeing people getting more and more demand. Why do you stand people down when there is demand out there? You just have to shift and change, but income maybe doesn't follow. So traditional fundraising routes were equally impacted. Sponsored events, the kind of community fundraising that we tend to do and get a huge amount of income from, all stopped. But there was also a lot of grant funding available last year that wasn't expected. I think many voluntary organisations will have secured more money than they expected because of the access to COVID relief funding that was available nationally and locally. But not every voluntary organisation, as I say, will have benefited from that. The smaller, the less connected, or those with less fundraising capacity did not benefit. And those who did, great. But a 6-month or a 12-month funding pot is not great for long-term planning. It doesn't help the health of an organisation. So it's something that isn't the solution, but the picture's a little bit more mixed on finances, I think. The challenge is more about what the next 12 to 24 months look like. With public sector finances likely to be squeezed for years to come, with grant makers having spent out a lot of money in the last 12 months on crisis relief, it's uncertain what we've got to look forward to in the years to come. Very hard for us to plan for that. And if we want collectively a voluntary sector that is vibrant and playing a vital role in supporting good later lives, we need to think about how we invest in that for the long term. And that brings me to the final impact, which I would raise, which is the impact on us in terms of our position in the system. Whilst more demand than we've ever had has come through in the last year, we've also seen our role squeezed from several sides. Local authorities have become more involved in coordinating support to communities in ways that have cut across some of the core work that voluntary sector organisations have done. Similarly, national volunteering, with moves like the Good Sam NHS volunteers, impacted on the availability and the role of local volunteering. I'd also argue that that experience that it offered to some volunteers who came forward but were never used may have set back those people that we hoped would come forward and want to play a part, but have had a slightly disappointing experience of volunteering as a result. Mutual aid groups, one of the phenomenal shifts that we've seen over the last year, showing hyper-local activity, neighbours organising to meet immediate needs of those around them. A terrific, one of the terrific positives of the pandemic, and potentially showing the way we would like our communities to be in the future, but it challenges the role of traditional voluntary sector organisations in that. We've been supporting these different initiatives, but we've also been undermined in part by them. So the key now, as we look at where that national, regional and street level activity goes next, does it recede away? Does it now ask us to come back again? Is to reconsider the true place and remit for the voluntary sector moving forwards. Which brings me to my final point and to the cliff edge analogy that I wanted to talk about, which wasn't about finances. I often come back to an image that I think was generated initially when I saw it by Paul Taylor at Bromford Housing. It's of a long sloping hill that peaks at a cliff edge, and at the bottom of that cliff are a number of ambulances parked. Now, I use this image an awful lot when exploring what the strategy should be for a voluntary sector organisation like Age UK Gloucestershire. Is our place, do we see ourselves in the ambulances waiting to pick people up when they fall off the cliff? Or are we on the hill doing the things that stop them falling off the edge in the first place? With an issue like ageing, especially given the demographic changes that we're facing, I believe strongly that our place is on the hill, doing preventative work that stops people falling down because of low income, poor health, a lack of social connections. COVID pulled many organisations into the ambulances. We have been responding and sustaining people at a difficult crisis for the last 12 months. As we recover, and especially with older age having been seen over the last 12 months as a vulnerability in a way more than it ever was before, we need to now climb back to the hill. We need to focus on proactive and preventative measures that I feel the voluntary sector is particularly well placed to deliver, and that will ultimately make a bigger difference than we can make if we just stay in the ambulances. Thank you.
Brilliant, Rob. Thank you. I think what a wonderful way to kind of distill the challenges facing the voluntary sector, and that image you've painted for us of the cliff edges is really something that we need to think about, where we want to place ourselves as organisations, the voluntary sector, and where do we think we need to be. Right, we'll move on to our third speaker. So I am delighted to be able to introduce Jan Thornton. Jan is a member of the York and North Yorkshire LEP Board, Vice Chair, Yorkshire Food Farming and Rural Network, Vice Chair, Community First Yorkshire, and Vice Chair of ACRA. So without delaying any further, Jan, over to you.
Thanks, Justin. Can I just correct you there? It's not ACRA, it's ACRE, which stands for Action with Communities in Rural England. So, but apart from that, yes, a wearer of many hats, I think is the thing to say. So, can we have my first slide, please? I can't see it. Ah, there we go. Right. Okay. Or second slide, even. Move on. Thank you. So, what might the economic impact of COVID be on older workers? Well, it's too early to see the full impact of COVID or Brexit. A lot of times Brexit has been forgotten under the COVID crisis, but early indications are that the impact of Brexit on some trade has reduced significantly in recent weeks. As far as COVID, once the furlough scheme finishes, there may be increased number of redundancies or reduced working hours. In the previous recession, statistically, more older workers were at greater risk of redundancy than young ones. Slide 3, please. So what are some of the particular challenges in rural and coastal areas? Well, the rural population has nearly 40% more people over 45 compared with urban areas. In rural areas, there are generally tend to be fewer job choices and lower wages. At the delivery of economic objectives by the local enterprise partnerships, or LEPs, they tend to cost more in rural and coastal areas, and there can be a temptation for programmes to focus on the urban areas where they are more cost effective to achieve a larger number of outcomes. And there are always greater mobility challenges in rural areas, whether it be the transport of goods, services, or people. And of course, as already been touched on, there are greater distances to travel and often minimal transport options for people to access training or education from new skills providers. And of course, the tourism and leisure sector, which plays such a significant role in the economies of coastal in particular, as well as rural areas, has been particularly badly hit due to COVID. Next slide, please. So let's have a quick look at the rural economy in England in general. 17% of the population lives in a rural area, but 24% of businesses are in rural areas. So that's a greater proportion per capita than in urban areas. Rural businesses tend to be smaller. 70% have 9 employees or fewer, and 18% are sole traders. 71% of rural employees work for an SME, and pre-COVID, quite a significant proportion of them were working from home. That will, of course, have increased massively in the past year, which is just one of the reasons why decent broadband and mobile connectivity are so important to the rural economy. And has also been demonstrated in the past year. Lots of small rural businesses have played their part in supporting their local communities, and their business values extend far beyond commercial constraints. Next slide, please. Well, I'm not going to read all of these out, but here are just a few of the areas in which there might be new opportunities for rural businesses and the creation of new jobs. So, next slide, please. So, in this post-COVID world, where are there going to be opportunities? Perhaps as importantly as rebuilding post-COVID is the low carbon agenda, and it's a major influence on how our economy is going to rebuild. Many local authorities have declared climate emergencies. The North Yorkshire LEP, similar to many others, has adopted the strategy to grow back greener, fairer and stronger. And other LEPs reference inclusive growth, in other words, improvements in the quality of life for everyone. And with the government's levelling up agenda, there are opportunities for this to include support for the rural economies versus the urban, and not just the north-south divide. And with the new Agriculture Act, this sector is particularly going to be undertaking massive changes in the next decade. And we would be here all day if we got into that. So that's a whole webinar all on its own. And there are lots of opportunities post-Brexit. In North Yorkshire, recent research has shown there are now 700 foreign businesses based in the county. And just as many UK businesses are opening in Europe, so too European businesses are opening up trading arms here, which has the potential to provide further employment. And whilst restrictions and uncertainty remain for foreign travel this year, after a slow start, it may hopefully see that the hospitality, leisure and tourism sectors will bounce back well, with an extended tourism season well into the autumn. And with newer ways of working being adopted and remote working from an office for part of the week will remain acceptable, there are opportunities for employment that are now potentially broader for rural residents. So in addition, there's a knock-on effect as well for market towns, as people working from home may pop into town for a coffee or do a bit of shopping, when previously they were commuting further afield to a larger town or city. So more of the spend will remain local. And many people have also changed their shopping habits and are supporting local food stores and farm shops rather than visiting large supermarkets. And it is to be hoped that this behaviour will remain. So just as small businesses have demonstrated their commitment and support to the local community, there is an enhanced appreciation by rural communities of the need to buy local and support local businesses. Next slide, please. Whilst there is no denying that redundancy is a very stressful and worrying time, it can also provide the opportunity for a re-evaluation of the type of work or sector someone is employed in, and can provide a catalyst for change, particularly if their domestic circumstances have changed. So some people, for example, often need to balance their work commitments with caring roles for elderly parents, and they may have only had little respite from the familial responsibilities, as their children may not have left home for very long. So post-Brexit, we are coming into the last couple of years for delivery of European funded programmes, but there is the UK Shared Prosperity Fund looming on the horizon from next year. And this is likely to provide continued support to SMEs, as well as to continue with the provision of support to those looking to retrain and upskill. One of the biggest barriers to the growth of UK businesses is their inability to find the right people with the skills they need. In the previous recession, a significant proportion of the older workforce were made redundant, but many of them chose to set up their own businesses. So support is currently available to those considering a startup, and this is likely to be maintained for the future. In Scarborough and Bridlington, there is a project called Advantage Coast, and that provides employment support both to increase employment, but also to support the creation of new jobs and help those furthest from the labour market to improve their employment opportunities, as well as helping improve the skills and experience of unemployed people. Next slide, please. So, what does the working older population have to offer? People often underestimate the valuable experience and skills we have all developed, often merely from having been around the block or having seen it all before. And the Chinese have a saying that once people reach 60, they are venerable. That's venerable, not vulnerable. So our wisdom is not to be underestimated. There is the added advantage that older people do not tend to be restricted by childcare constraints and may be able to work more flexible hours. For some, the less traditional avenues of employment, such as working for a community enterprise, might be an option, and particularly for those looking for part-time opportunities or wanting to do something fulfilling, and for whom income is important but not the sole driver for employment. And looking at the care sector, there are always staff shortages, so that's also an avenue, particularly in rural areas, as outlined by Jessica earlier, especially as often older workers have developed empathy for the elderly, possibly from the experience of looking after their own parents. Next slide, please. So here I've just included some links to some national resources that might be helpful, and also the link to the Advantage Coast project. And I'd just like to end on a not on a doom and gloom, and hopefully a bit more upbeat, but sometimes when there's been massive disruption, as there has been, that also provides a catalyst for change. And I think there could be some really exciting new opportunities that will be coming up that we can't even foresee. We wouldn't have even foreseen 2 or 3 years ago in all sorts of avenues. So I think older workers have got an opportunity. The other thing, finally, is that because there are more older workers and fewer younger workers in rural areas, there's an opportunity perhaps where they might keep a job or get a job that might have gone to a younger person in an urban area. Who knows? Thank you.
Great, thanks, Jan. That was fantastic. And some of those key messages are really in line with some of the things that we've been talking about for a while now at the Centre for Ageing Better, in terms of the strengths that an older workforce can provide, and actually stopping talking about this, the vulnerability, and actually all the advantages that a multi-age workforce can provide, that very much builds on the strengths of our older workforces. So thank you ever so much. That was fascinating. And we will move to our final speaker. So Glenn Garrard, Executive Director of Adult Care and Community Wellbeing, has joined us by telephone. I think with some of the challenges we talked earlier about the digital infrastructure, perhaps providing us with a little challenge. But Glenn, I'll hand over to you. Thank you.
Thank you very much, Justin, and it's a real pleasure to be able to join everybody. I can see there's 132 people on the call, so that's excellent. Can we turn to slide 2, please? And whilst we're doing that, I should explain that my responsibilities cover adult social care and public health in Lincolnshire. So welcome to Lincolnshire. Many of you will already know that it's a beautiful place, with lots of natural offers for the tourist, which is one of the reasons why the economic effect on Lincolnshire is probably going to be quite profound, along with many other coastal communities. We have relatively low housing and capital values, low crime rates. I know I'm beginning to sound a little bit like location, but it's perfectly true where Lincolnshire is concerned. And a relatively relaxed pace of life. We are also on the dry side of the country, although that's something of a misnomer, because whilst in Lincolnshire you may not need an umbrella, you are highly likely to need a pair of wellies, because the water table is very high. So the consequence of certain times of the year is that we flood regularly, which affects our ability to secure access, and indeed affects our coastal hospitals as well. Next slide, please. I also should mention that Lincolnshire's got the 4th most dispersed set of communities in the country, because we have very few urban centres. What that does mean is there's an exaggerated effect on how to get services to people, and the corollary of that, how to get people to those services. It's a major challenge for us. Added to which is the ever familiar age profile, which we are something of an extreme example of, and significant inequalities that add to that particular picture. We do not represent a north-south divide in the county, as big as it is. We tend to represent an east-west divide, where coastal communities are typically older, less confident, and also less easy to access. It is also the case that for those coastal communities, it's also much, much more difficult to recruit people into professional grades, because it's far further to go in terms of onward progression and professional development, particularly for clinical colleagues. On the west side of Lincolnshire, the transportation system is much improved, tend to be much younger communities and more confident. And that's influenced in large measure by the presence of an ever-growing university campus based in Lincoln. Next slide, please. So, why did we want to partner? Well, there were two particular opportunities that we felt. One was that we wanted to continue to use every opportunity we had to influence government thinking, recognizing that the year ahead, post-COVID, is one in which we will likely have a very busy legislative program from government. Haven't been able to do as much as they might during the COVID period. A lot of that will impact on social care, health, and public health. Lincolnshire can be typified by a very pragmatic approach to service delivery and a long history of finding collective endeavour. We have over 380 different social care providers in Lincolnshire. It's very difficult to have a relationship with 380 providers. So we've supported the sector to come together under an umbrella body called Linker. That's proved terribly successful and also gave us a high level of resilience in better coping with the challenge of meeting COVID as a pandemic. At the same time, and picking up on earlier points made by colleagues, we have also begun to support the voluntary sector, which is even bigger than the social care provider market. And as colleagues have indicated, very, very different in terms of the scale of provision, the nature of provision, and the engagement with the statutory sector. So we have begun with partners from the voluntary sector to support them to form an umbrella body that is better able to engage with NHS and county council colleagues. We've also undertaken a lot of work with our district council colleagues, of which we have 7, I think we're the same as North Yorkshire, in developing specialist housing options, and more on that later. We've also got a long-term range of integrated services and community-based services, not least with our partners in East Lindsey District Council, which is about trying to encourage better diet and more activity. Lincolnshire struggles with activity levels, which seems counterintuitive given the beauty of the nature around us. But nevertheless, activity levels are far lower in Lincolnshire, and particularly for the at-risk groups, it's a key point that if you want to have a better old age and a healthier lifestyle, activity is an important contributor to that. So that's a really big topic for us. We've also got a number of county-wide alliances around the Health and Wellbeing Board, a recently approved integrated care system. And by the way, we have the 4th largest pooled budget with the NHS in the country. So a lot of history of joint work, trying to find every ounce of effort from the scarce resources that we have. The Housing, Health and Care Delivery Group, I've already hinted at, is a forum that brings together the 7 district councils, the 5 NHS bodies and the county council to think more about how we can better use our scarce housing resources to serve the people of Lincolnshire better. Government policy tends to be very limited when it comes to older people or people with profound disabilities. It tends to focus more on environmental standards and building design. And in Lincolnshire, we need to balance that rather better by coming together to deliver not just improved housing with greater choice, but also making best use of disabled facilities grants and our equipment service. Next slide, please. So our experience of COVID, during the last 13 months. Wave 1 was relatively low rates, low transmission levels for us, and that particularly had a limited impact on our care homes, which allowed us to probably maintain a better experience than many other parts of the country. We have mostly small to medium enterprises in social care in Lincolnshire, which means that the previous structures that we had for communicating better were really, really helpful in making sure that all providers had the necessary support, for example, with PPE kit, and we were able to pick up on problems quickly and respond to them. We've had engagement with a significant number of clinically extremely vulnerable people, and very quickly we're able to repurpose our existing services to support them, many of whom would not have typically been known to social care or indeed to the NHS in large measure. We've also identified a large program of support from voluntary sector colleagues, but also recognised that there's quite a distinction between voluntary sector activity and community activity. And we're trying to, as it were, find the better ways of supporting colleagues in the community who have undertaken support to local people in a way that illustrates the very best of community spirit. So there's two levels for us in dealing with this. One is to support the voluntary sector more, but also to support community groups who aren't necessarily part of the voluntary sector. We've also engaged a lot more with unpaid carers, family and friends. Some extra detail is there, and a much higher level of interaction with carers than we've seen before. We've also had a very strong vaccination up that seems to have been impacted largely because of our right-sided ageing profile in the community. Next slide, please. So, one of the things that we have realised in Lincolnshire is that we have a strong community spirit based around place. Our experience of working with those communities, those connected communities, is something that we want to prioritise in the coming year, both across the NHS and within the County Council. There has been a significant growth of community action groups and a lot more work undertaken through digital and digital channels. Again, recognising that access in a place like Lincolnshire is terribly difficult. Digital has become a much stronger evolutionary step for us, not just in terms of professional practice, but how we engage with each other and how we tackle such things as social isolation. Next slide, please. So, building on a strong history of collective endeavour, we feel that there are significant opportunities in the coming years to further enhance our support to the voluntary and community sector, to maximise individual and community resilience, particularly for people over the age of 50. So working further upstream to better support people in advance of them needing health and social care, along with that important issue of what services have we currently got that we could recalibrate with the experience of COVID, so that we are more likely to be able to better respond in the future when pressures emerge post-COVID. And we are expecting quite a number of those. For example, in mental health, domestic abuse, safeguarding, and so forth. One of the key things that we've learned over the last year is that if you've got good quality relationships, if you've got strong communication lines, and if you're able to engage across different sectors, you're more likely to be able to join up the dots and better support local communities. And I'll leave it there. Thank you very much.
That's great. Thanks, Glenn. A fascinating picture of Lincolnshire, and what I seem to sense as a sort of a bit of hope and commitment there from a local authority, excuse me, and a bit of a role model that we hope that other areas will follow in terms of those commitments, particularly in relation to the voluntary sector. Excuse me. So we'll move rapidly on to the Q&A session. I can see that we've got a number of questions that have been posed into the Q&A function on Zoom, and we'll get through as many as we can. If perhaps first I can, I'll pick one out and ask one of my panel members to maybe start us off. So Emma has posed as a question around digital exclusion being a significant issue for older people, and the impact that COVID has had on this, particularly in rural communities. What solutions does the panel recommend to understand and address the complex reasons people are offline? And I wonder if I could ask perhaps Rob to respond initially to that, and then ask other panel members to join in.
Yeah, thanks. It's a really, I mean, it's a very live question, isn't it? It was live long before COVID, the digital exclusion, but it's again been really shown to be how prominent an issue it is. We've certainly seen from our research that, you know, the suggestion that all older people are offline is clearly flawed. There are many that have benefited greatly and have enjoyed the benefits of digital connection, but there have also been many others that haven't and have felt therefore even more excluded. Interestingly, we're just exploring in Gloucestershire a response to this that is a county-wide one that tries to really understand what are the barriers, what are the current assets, and where are the gaps in linking that. And I suggest that as a good way forward, because what we've seen is an explosion of people that want to do something around digital inclusion. Lots of projects get out there, but they're not connected, they're not joined together. And it may be that there's a particular area that's getting a whole load of investment and others that are getting none. And these are really broad issues, because the exclusion comes because of infrastructure, it becomes of hardware, the access to actual kit, and it comes to skills and confidence. And at the moment, we've got some solutions that are trying to tackle a bit of that, and potentially a bit of that in one location, but not across a whole patch. So we're about to start a piece of work in Gloucestershire, as I say, that's looking at, well, let's map the whole county, let's map what's really going on, looking at all ages, let's looking at all geographies, and understand where we are, and then try to pull the various funding pots together to say, where do we address this strategically, rather than just trying to hope that by spinning 1,000 plates we'll get more people connected. Because I think it's a much more strategic question now than it probably has been in the past.
Great, thanks, Rob. Any of our other panel members want to add to Rob's response there?
Yeah.
Go, Jan.
Hi. I think this, yeah, I completely agree with what Rob says, but I think there's a whole lot of elements of stuff, and sometimes it's well, the first thing is actually access to broadband is a big thing, and there has been quite a lot of work done in Wales whereby they've created digital hubs in village halls, so that you can then really get some really decent broadband in one place, even if you don't have it in the whole of your village. So I think there's some real connectivity there. And within Yorkshire, we had a project 2 or 3 years ago where we gave iPads, this is pre-COVID, we gave iPads to a group of elderly people because all they wanted to do was be able to look at photographs of their family or to be able to speak to them. And if you'd said to them, oh, well, you've got an iPad and you can do all these things, they go, no, I don't want that. And it's keeping it simple. And they all came back and went, this is fantastic, can you teach me more? And I think there's so much actually, isn't there, for older people particularly, about how you how you help them to dip a toe in the water if they're feeling a bit reticent about it, and how you help move them forward.
Great, thanks, Jan. We've got a couple of questions posted in.
Muted yourself, Justin.
Sorry, thank you. We've got a couple of the questions in the Q&A box, which are around the voluntary sector. So Kerry has posted as a question around the challenges around just the sheer effort and how people have worked tirelessly across the year to be able to respond and keep going. And there's a question there about how do we get this recognised and the effort that needs to go into this. Alongside it, a question from Paul about the funding for the community and voluntary sector, and how do we make sure that the sector is supported longer term? And I wonder if I could ask Glenn to respond to that first.
Yeah, thanks, Justin. I did read Kerry's question. Just first of all, thank you, Kerry, for what you're doing. That's a brilliant example. And again, draws out this distinction that we're beginning to see between community activity and volunteering. And they're not necessarily the same thing or need the same responses. But with my health colleagues, we're beginning to look at, and our district council colleagues, what we can do to better support you. And of course, the first thing is to recognise that you're there. And we've got some 600 community groups looking at this. So my Director of Public Health is doing a joint a strategic asset assessment. We usually do a joint strategic needs assessment. So an asset assessment is trying to raise the profile of community groups and the voluntary sector as part of our understanding of where we need to put, as it were, the resources we have, that scarce Lincolnshire pound I mentioned, to better support people working upstream. By the time they come through my door, they're typically going to cost a lot more and maybe not get such a good outcome as we might have been able to provide if we'd worked further upstream in a more preventative sense. So we have a number of programs working through some of the district councils, East Lindsey I have mentioned, but I'm expecting more. And if Kerry wants to email me, I will see what I can do to draw some connections for her. But if I may, Justin, the point about digital is terribly important. And previous colleagues have mentioned the importance of broadband, but I also think it's important that people are aware of what the existing retail kit can do to help them retain their independence and their connectivity. We don't necessarily need extra bits of kit beyond what's available in the stores at the moment. And just accessing some of that is a really big step for some people in terms of reducing social isolation.
Great, thanks, Glenn. Jessica, I wonder if you've got anything from your sort of insights nationally in relation to the questions posed around the voluntary sector. Before we come to Rob, I'm sure we'll have some views.
I do think there is a recognition within NHS England that was there before the pandemic, but is definitely been illuminated by the pandemic about the role of the VCS and some of the things that Glenn is talking to us about this morning. It's very much now seeing the VCS as an equal partner, and certainly some of the structures that we're seeing come through now, like integrated care systems, the VCS absolutely has to be at the table of that and is not at the table as some token gesture because we need a VCS rep and we need to tick a box. It's very much involved in that evolving ICS and the work it's going to do. And the points around digital from an NHS perspective, it's a means, isn't it, not an end in itself. And it doesn't, as per Glenn's point, need to be complicated or expensive. So if you think about the Airedale Trust, some of their offer is on the telephone. It's not all kind of video conferencing. And we've certainly at the National Centre had trusts who have been involved in some really interesting technology projects. And those have been pilots. They've had lots of expensive kit. And then when that pilot's come to the end, the trust hasn't had the funding to kind of continue that investment. So I think, and the other point I think is really important is that we need to make sure we're capturing the benefits of the technology that we're using. So often trusts are interested in whether or not it will reduce hospital admissions, but actually then there might be benefits elsewhere. So I think it's important we capture those too.
Great, thanks, Jessica. And Rob?
Yeah, I think this question gets to the real heart of it for me, which is if you want a vibrant voluntary sector, if you want a vibrant community sector, you've got to support it. I think we've been very, very fortunate that it's been there through the pandemic. And I would pose the question to all really to think about, imagine if it wasn't. Imagine if we hadn't had the voluntary sector we have now for the last year, and imagine if we hadn't had the community response that Kerry and others put forward, we would have been in a really precarious position. Now, the danger is that politicians at the most senior level, but also cascading through, see that as being, well, it's always there and it mops up the pieces. And it has to move from that. It has, as Jessica said, got to be a proper seat at the table. There's a really powerful, I think, comment that's often made in relation to community building, which is you make the relationships with your neighbours before you need them. And what we've seen through COVID is those connections have been forced together, and we've seen the power that's there, but we can't take it for granted and wait for the next catastrophe to come along for it to expect it to happen again. What we need to do now is go, well, how do we invest in building those communities to make sure that they are robust for fair weather as well as foul, but so that the places that people live are much more sustainable? When we think about the demographic change that's coming, the responses to that will not come through services that Glenn commissions. They will come through our communities changing and responding to be more inclusive, responsive, safer, healthier places to live, meaning that a smaller number of people require statutory intervention. But that won't happen automatically. Now feels like the time for us to invest very squarely in how do we make our communities age-friendly? How do we encourage and support communities to come together in the way that Kerry has been doing? My one caution with Kerry's point is the pursuit of wanting to be paid for it, and the danger that we suddenly start creating a whole host of brand new community neighbourhood charities, because I would say, as a charity leader, stay away from charity governance as long as you can. The answers to this are not to create more bureaucracy, it's to build on the energy that we've got that means that people want to help each other, but not to take it for granted, not to assume it will be there and we'll keep on doing it forever. There's got to be a new way. And one of the real positives, I think, for me over the last year is I've not had to do commissioning work in the same way. So funding has been released for community and voluntary action in slightly softer ways that have trusted our organisations better and have talked less about 30-page tender documents and KPIs. I think that's a really important benchmark going forward, that if you truly believe that the voluntary sector and the community sector has got a seat at the table, it needs to be trusted more and not put through the ringer to try and prove itself and kill the energy of Kerry and colleagues that's really making places better places to live.
Great, thanks, Rob. It feels like we've kind of had a really lively response to that question across the panel, which is great. Jan, I wonder if you'd mind, there are two questions I'm just looking at, which I wonder if you'd mind giving us a starter on. So one is about the move to remote working, reducing the impact and the sort of lack of job opportunities in rural areas. And the second one is a question around sort of poor public transport in rural areas, especially in North Yorkshire, and the kind of the lip service that is felt to be paid to that problem. So I wonder if you could pick up those two for us and we can follow on with the rest of the panel.
Yeah, and that they are sort of interlinked to a degree, of course, because actually if you haven't got decent transport, how are you going to get to a job if you haven't got a car? Yes, I think I agree with the point that I think outlined, is that there are possibly, assuming that you've got decent broadband, there are opportunities that are going to be for people to work more remotely, and they don't need to be quite where they are. They don't need to be so local for the commute. I think there's a further interesting development that's happening across the country with that. And this is the concept called multi-locality. So where you've got people who've got a second home who say, well, actually, I'm going to spend 3 days of the week there and work, maybe work there Friday and Monday, and then I'll only go back to my other main home, for fewer days during the week. And that also causes some issues about the funding of services and how those are measured. So we know with the census, you decide where is your main home, and that's where the local support services go, for the hospitals or everything else. So there are all sorts of issues that are going to be raised as a result of the way people working differently. But yes, hopefully there will be some better job opportunities. But as far as transport, yes, that is a really massive thing. And I think one of the things that has to be recognised is that there aren't going to be greener easily transport solutions in rural areas, and that people in rural areas are far more heavily reliant on a car. And there's usually, you find that fuel costs more in a rural petrol station than an urban one as well. And there are all sorts of issues. And I don't know how we're going to solve all of that, but I do think there's going to be fresher, different looks to how that moves forward. So, for example, having Uber type, calling up the bus on an app rather than a bus that drives around loads of villages, and is empty most of the time and is too big, and all those sorts of things. So I think there will be some innovative opportunities that will come up in the next few years. But the problem is, at the moment, is you've got to be able to afford the transport, and you need your own car. If you're going to have electric vehicles and going down that route, that is far more costly alternative or way to be greener at the moment, because it's still expensive. There's all sorts of digital infrastructure problems about getting electricity and for charging of vehicles to remoter places. So there's a whole can of worms out there, but we haven't got time for all of that today.
Great.
I don't know if that's helpful, really.
That's really helpful. I'm just looking around the rest of the panel to see if anybody else has anything to add to your response there. Rob, do you want to come in?
Just one point, which I think is to draw in the comparison, that if more work's done at home, if there's less commuting, if that makes bus routes less viable, that will impact on older people too. So there is this potential trade-off that's not going to be helpful for older people who are already are slightly nervous about getting back onto public transport at the moment, but are also seeing routes looking more vulnerable, and the danger that we lose more, we accept that commuting's going off, that will have an impact on older people in rural areas too.
Great, thanks, Rob. We've only got a couple more minutes really left for questions, but there's a question that's been posed around where does social prescription come into healthcare in the community across the UK? Is it used in some places more than others, and how effective is it? I wonder, Glenn, if you'd offer us a first response to that, and then I'll come to Jessica, perhaps.
Thank you, Justin. So my wife is a GP, and I think she would say that depending upon what the social prescribing offer is, it is beginning to have a material impact on GPs' ability to better serve their local patients. But in a way, it's also a matter of how well joined up social prescribing is with all the other things that are going on in a local area, because it's easy enough to introduce a new initiative. It's far harder to make that new initiative joined up with and strongly connected to the shopping list of other things that might be available. So in Lincolnshire, we have a wellbeing service that supports about 7,000 people a year, and it's ostensibly a preventative offer. It's run, though, by the district councils, who use an awful lot of voluntary groups in those areas to support, in terms of capacity, a range of services. Social prescribing is coming through the NHS route. So the trick here is to make sure that social prescribing and what's going on in the districts and the county as a whole is seen as a list of options available to people, and doesn't come across as a confusing array of options, and you've got to go to different places to get them. So if you like, trying to get that brought together into an easily digestible package is probably the main challenge for us.
Thanks, Glenn. Jessica, would you like to offer some thoughts?
I think social prescribing is really important, and there's a kind of national move to promote social prescribing, but it's kind of links to what Glenn's been saying and Kerry's question previously. We now have primary care networks, which are clusters of GP practices. They're now appointing some of them what they call link workers who are going to deliver that social prescribing locally. And it's about thinking about how joined up they are. So do they know everything on the shopping list? And I know certainly in Cornwall, they've got the Cornwall link that tries to to put all of that information in one place. So the link workers can go in there, and so can anybody else from the statutory sector or the voluntary and community sector to find out what's happening. I think social prescribing's got a real offer around prevention, early intervention, and kind of improving health and well-being, so that people don't end up needing to access some of Glenn's services.
Thanks, Jessica. Rob or Jan, do you want to come in on that point? Rob?
Yeah, if I could, yes. I think, so we had a very strong village and community agent process within Gloucestershire long before social prescribing got the recognition it's got now. And what we've seen over the last few years, I think, is it getting pulled more and more into core business of GPs, very much a top-down NHS view of this feels like a good idea. And I would say it's lost something as a result of that. And I think particularly through COVID, it has lost something as people are not going to the GPs. And we've seen our social prescribing service, I would say, less effective because it's not rooted in the community anymore. It's linked to the GPs, and they have felt a little bit more isolated over this time. I agree with colleagues, it's got such a phenomenal potential around prevention, but I think at the moment it's been pulled away from that slope of the cliff top, and it's been a little bit more in the ambulance. It's when you're already appearing at the GP regularly, you get referred into the social prescribing, rather than saying, how do we get a vibrant community that's trying to stop you getting to the GP's door in the first place? And I think we've slightly in danger of over-servicing the model, as opposed to seeing what is it trying to do, which is not prescribe things, it's trying to connect people to what's going on in their community. And I'm not sure that the GP's hub is the right place to put all the energy. Yes, it's the end point that we need to support, but what are we doing before that to build communities, to build the connections, to build that smorgasbord of things that you can pick off to allow people to know what's going on? I think we've over-operationalised it, is my view at the moment.
Brilliant. Thanks, Rob. And that really brings us to the end of the time we've got for questions. We've had so many questions posted, and apologies to anybody who's posted them. We've not been able to respond to them. We will kind of pick them all up afterwards, and we'll be thinking about what we want to and need to put out into the community and people that have responded in terms of a blog or other communications to kind of pick up some of those things. So I have the task of thanking everybody. It's been a really, really lively and interesting discussion. Really a huge thank you to our speakers. I'm sure you'll all agree that the insights that we've been brought today have been fantastic from a number of different angles. And I'm sure you'll all join me in a virtual hand clap of thanks to our speakers. We'll all take away a range of insights and ideas from today's discussion. It's really quite challenging to kind of pick out just a few kind of key points for me, but I was really taken when Jessica was presenting, talked about those 4 areas: workforce, distance, size and access, but also the good practice opportunity at the end, and those different examples from across the country around how we tackle each of those 4 areas. When Rob was speaking, the way that we kind of distilled down into those 5 areas of impact of COVID on the voluntary sector. But again, that cliff edge image that I think we've come back to a couple of times, which I think is really, really strong and powerful, that we should hold on to, and trying to make sure we're on the hill, trying to stop people getting to the top rather than waiting at the bottom. Jan painted us, a number of opportunities for the economy, the low carbon agenda, levelling up, the opportunity in tourism and other areas to kind of bounce back, and the strengths provided by an older workforce, which I think is a really important point that we've got to hold on to, and we continue to kind of build into our programs of work. So really strong things there. And for Glenn, he painted us a picture of Lincolnshire. We're certainly delighted we're in a partnership with our colleagues in Lincolnshire, but there was certainly a sense of sort of hope and commitment from that local area that's a really good role model for other areas to follow. So huge number of sort of key points in there. We'll be circulating the slides and a link to the webinar recording to you all and publish it on our website. If I can give a little plug to our next Aging Better webinar, which will be next Thursday, the 22nd of April, and the topic of age inclusive workforces. So that picks up on some of the points that we've actually picked up today. Details are just being posted in the chat, and they'll be on our website for people to be able to join that too. Please do take a moment to tell us your thoughts about this webinar. A link to the feedback form has just been posted in the chat box. And finally, I'd just like to say a huge thank you again to everybody for taking the time to join us. Huge thanks to our 4 speakers, and goodbye. And I hope to see you all soon.